Good morning. You guys are in the CDH breakout session. It's a huge room. We'd love for everyone to come up closer. I feel like an elementary school teacher. We have a fun team today. We are all about fun. We have Katie Russell, and wherever Katie Russell goes, fun follows. And we have Natalie Rentoul, who, I don't think anybody realizes how much Natalie does. Like, she organizes everything. She knows everybody, and she makes everyone feel important, and she gets this international group together of crazy people to talk about how we all manage CDH actually differently. So that is one of our issues, right? I just think we should briefly introduce the team. Everybody come up. Yeah, and the slides are loaded.
Does this mic work?
So are the tapings for good things or bad things? Look at the high sign. Are you ready? Oh, baby. All right. So this is our team. Does everybody want to introduce themselves quickly? I'm a surgeon from CHOP.
I'm Katie Russell. Wow, that's loud. I'm Katie Russell. I'm one of the pediatric surgeons at the University of Utah at Primary Children's Hospital, and I had the pleasure of training with Dr. Hedrick.
I'm Lakshmi Raman. I'm a pediatric intensivist, and I'm stuck in a neonatal session. Just kidding. And I have the pleasure of caring for these children when they come on ECMO in the PICU, so that's how I got recruited to this session.
Good morning. My name is Diana Vargas. I am a neonatal cardiac intensivist, and I work at Columbia University. We have a general NICU and an infant cardiac unit where we do all ECMO, cardiac, and respiratory for all infants. And I'm the neonatal ECMO director, which is how I was invited to the meeting. Thank you for the invitation.
Good morning, everybody. I'm Matteo Di Nardo from Rome. I'm a pediatric intensivist. In my hospital, we manage the respiratory cases in my unit, so also the neonatal case. I'm happy to be here, and thank you for the invitation.
Hi, good morning. My name is Nathan Raffat. I'm a neonatologist intensivist from Mannheim, Germany, and we have a large center for CDH patients.
So that's one of the themes. It's the richness of the different perspectives that we have here today. And so this is the group of folks, and all really corralled by Natalie. We had a really fun phone conversation where we rattled on, and it could have gone on for 8 hours. I think it was a couple of hours. And there were some big buckets that kept coming up over and over again. And so, this session typically focuses on surgical repair timing. And so we just thought we're kind of sick of that topic. So let's talk about something else. And so these were some of the big buckets. So transport, do you transport in? Are they inborn or outborn? Katie Russell's going to cover a little bit of that. Cannulation parameters, initiation, types of pump and equipment. We weren't all using the same thing. The surgical pearls, there's just a few that we'll try to not be too obnoxious. And then team dynamics, like who's the leader, who's the decision maker? We had some little controversy in who that might be. And then the complications, ventilation strategies. I do wish that we could hammer that down. I mean, we're all over the place on that. And so ventilation strategies, both before we go on ECMO, when we're on ECMO, and as we're coming off. So these are all over the place. And so we're going to just hear a smattering of what people are doing. And then finally, decannulation. So with that, just to harken back to Natalie's talk yesterday, you have to meet the baby, and we do try to be personalized and individualized about this, despite our needs to sort of have some recipes for how to do it. And so the issue is knowing your rationale, and so you can do different things, but as long as you have a good reason for it. Somebody else said that yesterday. Was that you too? Oh, that was Yet Gunner. So surgical repair, so timing seems to be our focus. So we'll touch on that a bit, but not really. And then, the actual techniques have actually sort of evolved over the last few years. Katie and I'll touch a bit about that. And so it's this on versus off, early versus late. What's the definition of early? Is it 12 hours? Is it 3 days? Is it 1 week versus late? And there's all these influencers, right? There's these single center studies, single center series where people have had good results, and then there's seems to be a wave will happen for the next several years where everybody kind of swings one way and they start trying to all do it like this one, successful single center, and then it swings back again when people maybe don't have the same or equivalent outcomes. There are CDH registry studies that sometimes have the same data source but different conclusions. Matt, I'm talking to you. I saw him somewhere. Also registry, again, the Canadian CDH Collaborative, the CDH Euro Consortium, CHNC, which has work groups and is very dynamic, and this might be the theme of the day. It's a dynamic process of sharing and perspectives that we really want to focus on. And then social media. I mean, the parents are getting involved, right? They're all talking to each other. They actually come to you with posts. They're all giving each other advice, and so we have to deal with all these things. And so, again, just to reiterate our theme of the day, you have to meet the baby, and knowing the rationale is the difference maker. And so variation is a theme. This was a year or two ago in CHNC, just showing the timing of surgical repair. And so it feels like everybody's doing it early now, but if you actually looked at the survey, it is still all over the map. And so some of the loudest voices are doing it early. So the number of centers and just showing that variability. And then, even amongst ourselves today, we're very variable in terms of how we do it. So Rome is repair immediately. Matteo told us he would call a surgeon in at 2 in the morning if it is necessary, because that's what's right for the baby. And he'll talk a little bit about that later, I think. And then at Chalk, Utah, and Dallas, it's early, is sort of 48 to the first 3 or 4 days. At Philadelphia, we about half the kids that go on ECMO we can actually get off, and we feel great about those. It's the other half that we don't feel so great about that we need to repair on. And I think that we have really started to think that we should be doing it earlier rather than later if we're going to do it when they're on ECMO. And our early definition is not 12 or 3 days. It's probably sometime in that first week when their cardiac issues have resolved. And then Germany never repairs on ECMO. So just amongst us ourselves, we have very different groups. We know that it is a much bigger exposure if you're going to get repaired on ECMO. There's all these complications that we have to think about in terms of bleeding, fluid shifts, hemodynamic shifts, and in a group of patients from our own center, about 40 patients we looked at, their neurodevelopmental outcomes were worse than the ones that were repaired on ECMO. But we know that there are worse phenotypes, so it's a little bit hard to know exactly where to come down on that. But this is those kids and their neurodevelopmental scores. Our pump types are even different, and we're going to hear about that in the session later today around 4:30. There's a neonatal breakout session that's going to talk about centrifugal versus roller pumps, and amongst ourselves, we're half and half centrifugal and roller pumps. Where do you guys fall? And then finally, we're going to end our little part with a few of the details, not necessarily the timing, but the details about the surgical repair. And so, we know from the CDH registry that if you need a patch, depending on the size of your defect, the A, B, C, D, that really matters, and that's associated with your outcomes. We, for years, were really big proponents of the Gore-Tex patch. We used it a lot. And we actually wrote a little paper that said, oh, it's pretty good. Why is everybody so worried about it? But it's all about where you draw your brackets. So we had a few good years, and we published that we had very few recurrences, and we didn't know that we had any infections. And lo and behold, somebody shows up with the bump that you can see. I don't know if this is a pointer. There's a little bump on that baby in the middle. And this was actually a patch infection necessitating out the child's back. And so we've had about 10 devastating patch infections, and the average time that they present is 400 days of life. So it's way out. And so you need to follow them long enough to know that this is going to happen. So with that, we have jumped on the muscle flap bandwagon, and I don't think I've done a Gore-Tex patch for a couple years. So this is brought to us by Utah and popularized by the group there, and we're definitely believers in Philadelphia now. So with that, Katie's going to get up and talk about those.
Yeah, hi everyone. I think using a muscle flap has been standard of care in Utah since the early 90s. I think we've only placed 2 or 3 patches over that whole 30, 40-year time period. The first paper we wrote was in 2003, where we kind of reported our first 8, and it was really popularized by Dale Johnson, who was the founder of our group. Mark, do you do all muscle flaps? So very interesting. So we have a previous fellow who is not doing muscle flaps. I trained at CHOP. Oh, okay. So, I mean, that's a good point. So if you're going to do them thoracoscopic, then you wouldn't do a muscle flap. That makes sense for sure. I certainly, since I got back to Utah and kind of watched some of my partners do it, I have totally transitioned to, if you need to use some kind of repair, to doing a muscle flap. There's also several ways that you can do it. I would say about half of us just use one layer of the abdominal wall, so you just flip the transversalis over and just use that one layer. And about half of us use the transversalis and the internal oblique, which was the original description in the paper, was to use it 2 layers. I don't think that it's probably still out there. We don't know if one way is better than the other, but there's kind of multiple ways to do it. And then with that comes the question, so can you do this on ECMO? And I think we've written one paper. It's a small study, but we do think that it's safe to do a muscle repair on ECMO. And just with that, you need to be careful, that you don't get into significant bleeding and use electrocautery when you're doing the dissection, et cetera, but you certainly can, and we've shown that that's safe. And I know that the CHOP group also has done multiple of these repairs on ECMO.
Sorry.
No problem. Anybody else in the audience want to make comments about flat versus patch on ECMO? Yeah, Mark.
Sorry, Mark Molitor.
This is getting ugly, the old fellow. This is getting real
The
ugly.
caveat of this whole thing is I
I
trained in Salt
called
Lake
on him.
City.
I started this.
So, Mark Molitor, Phoenix Children's, I trained in Salt Lake City as their first pediatric surgery fellow. So I was a muscle flap believer while I was there. Phoenix was not a believer in it, so I had a hard time convincing them to do it when I got there. But what I will say is, for 2 years I never saw a recurrence. But in my 10 years in Phoenix, I have taken care of 5 kids from Salt Lake with muscle flaps who have had recurrences. Just curious what you guys are noticing.
Yeah, I think that we certainly have had one in the last couple of years. But I think that's due, we have 100 patients with muscle flaps in our cohort. So clearly that's something that we need to go back and look at what the actual recurrence rate is. We did write a paper showing that our flaps and our patches were equivalent. But I think that, now 2022, it's time to kind of relook at that data.
Hello. So we can get set in our ways at CHOP a little bit. So we did patches for 20 years. We said they were awesome, and I think we've had recently, we're about to report on 10 really pretty devastating patch infections that happened from the time the kids were around, the average age was 400 days out from surgery, but we had a kid who came back at 24 years old, and he had ended up with a fistula and ended up having a fatal outcome. We had another one that was around 11, and his patch eroded into his colon, or the sutures did, and he was around 11. He had what they thought was just a polyp, and it ended up being it ended up being patch granulation tissue, and the patch was in a little bed of pus. And so there's those things that you don't know about unless you follow them long enough. That being said, we have converted to the muscle flaps, and so now we're only a couple years in, so it looks good so far. I think we've done 48 now, so not 100, but 48, and we haven't had any recurrences yet.
Anybody else want to make comments on type of repair on ECMO? Love to hear. Yeah.
Quick question about the thoracoscopic intervention. Is that something that can be done on ECMO, or is that often?
I would say absolutely not, but would love to hear Mark's opinion on that.
I have not, but I want to. Kansas City, I know he's not here, so I can use his name in vain. Jason Frazier has done 2 thoracoscopic repairs with patch on ECMO.
Wow. And what patch are you using? Gore-Tex. From the chest. Yeah.
Bob DiGeronimo from Seattle. I just also was in Salt Lake at one point, not that it's the disgruntled Salt Lake cred. I thought when I was there was some concern about later a higher incidence of scoliosis problems with kids that got
yeah,
muscle
that's
flap.
a great
Is that true?
question. That's the question that I get most frequently. So, you know, the question is, in kids that get a muscle flap repair, do they have a higher rate of getting pectus deformities and scoliosis in the long term? So what we did is we compared our flap kids to our patch kids and found the same rate. So our conclusion from that study was that it's actually just the large size of the defect that sets you up for those things, not the type of repair. But I think to Dr. Hedrick's point, you know, we really need to be following these kids long term. We now have a long-term follow-up clinic, and we're putting all that data together. Any other comments? All right. Well, I think we can move
Can I say
on.
one more thing?
Yeah.
I've worried a little bit about bowel obstruction. I feel, and this is totally anecdotal, but you know, there's a big raw surface area once you make that flap and flip it down on the anterior abdominal wall. And so we've just had, it feels like a little bit more sort of returns to the OR for license of adhesions, but we don't have the data.
Do you do a LADS?
We look and we put it back in LADS configuration. We don't get too crazy if they're on ECMO or they're, you know, we just sort of put it so the mesentery is as broad as it can be. We wouldn't like mess with the duodenum much if they were on ECMO. And that's where they get their adhesions anyway. So if they have a really curly cute duodenum, we tend to let it stay that way. But we would take any LADS bands that were constricting from the colon over down.
All right. I think in the last couple of years in Utah, we've kind of gone to the theory of the best ECMO is actually no ECMO. And in 2016, our neonatologist, led by Dr. Yoder, did a big, multi-pronged improvement project. So our kids are born at the University of Utah, which is connected by a bridge to Primary Children's. It's a relatively short bridge, but you know, it's not the same setup as that these guys have at CHOP where you get to just come straight downstairs. And so what we did is we, minimize stimulation, which I think everyone does, but we really minimize it. And we leave them at the University of Utah actually now for between 24 and 48 hours, and we delay our transport. We also delay echoes. We felt that initial echo really could stimulate the kid and kind of put them into pulmonary hypertensive issues. So we limit our echoes. We decreased our initial FiO2. And we also completely removed post-ductal sat monitoring. So we no longer have a post-ductal monitor, and we do all of our weaning and ventilator management based on a pre-ductal sat probe. We also limit ionotropes and boluses, and then what we do is we calculate the OI, and that's when we repair. So these kids are typically coming over and getting repaired within the first 48 hours of life. But since doing this kind of improvement project, what we've noticed is that we had a decrease in our ECMO utilization from 33% to 10%, and at the same time, we also improved our overall outcomes from 75 to 93%. And that's our experience. With that, I'd like to turn it over to some of our other colleagues. This is the forward button. It's kind of hard to see.
Hi, good morning. So you might know the situation, it's getting late at night and you're thinking of, oh, do I need to put the kid on ECMO or can I prolong the situation and put it next morning? So we were interested to see if the timing of ECMO has an effect on mortality and morbidity. So we looked at our patients for the past 10 years, and we included about 240 patients which were on CDH patients which were on ECMO. And we were dividing them at different time points. We divided kids which went on ECMO within the first 12 hours, then patients which went between 12 and 24 hours, then patients which went between 24 and 120 hours, and the last group, group 4, was patients which went to ECMO or put on ECMO after 5 days, after 120 hours. And what we saw was very interesting, that especially the first group going to ECMO on the first 12 hours, and the last group going on ECMO after 120 hours had the worst outcome, had the highest mortality rate. And for the first group, we were it was understandable. We could say these are the most severe cases. These are D defects. They have a high presence of extreme pulmonary hypertension. But we were wondering, what about the group which was higher, which went on ECMO after 120 hours? Although these patients had less presence of liver up, they were about 70% in that last group, whereas all the other groups had nearly 100% liver up. It was very interesting to see that, especially when we prolong the situation, when we have certain stress factors leading to pulmonary hypertension crisis, leads us to later ECMO initiation that leads to not only higher mortality, but in this group, the patients, they had over 50% of presence of chronic lung disease, whereas the very first group only had 25% of severe chronic lung disease. So therefore, we have to be aware of initiation. Timing is an important factor, and we need more studies to look which patient needs to be identified to be put on ECMO at what time. There's also a poster on this on booth 56 if you want to take a look at it.
So on the kids that did greater than 120 hours, did they have any other comorbidities? Like, were they septic? Could they have a UTI? Did they get diagnosed with bacteremia?
The infection rate was not high on these patients. They had no special infection rate. What they had was, what we see is they had certain stress factors, so especially that they would get acidosis, and this led to more severe hypertension, and that led them to have to put on ECMO. But there was no degree of higher infection or any other factor. And they were mainly C defects.
For your late group, were they repaired, unrepaired, or mixed?
All of our patients are unrepaired on ECMO. They are all repaired after ECMO.
Okay, but I meant for like the ones that went on at 100 and...
yes, they were all repaired.
Were all repaired?
Yes.
Okay.
Great question. Anything else? You got to give it a little more time.
Excuse me?
No, I was just kidding.
Okay, so we're gonna shift a little bit in terms of ventilatory management, and of course I have the pleasure to have a lot of scaffolding at Columbia with Dr. Wang's legacy. So we are very much based in his legacy of permissive hypercapnia. So we definitely, we do monitor both pre and post-ductal saturations, but we definitely just pay attention to the pre-ductal saturation most of the time. During the first 5 minutes, we allowed 60s, 10 minutes, 70s, and towards the first hour, we're aiming for 90, 80%. We do like to keep the differential at 15, 20 points, and definitely we have some concern when the post-ductal saturation is less than 70%, but we don't necessarily make any decisions based on one number in an isolated way. Our sort of like escalation algorithm starts mostly with conventional ventilation, like I'm pretty sure most of the centers would do. We definitely max our peak pressures at 20 22-25, definitely have gone higher. I would say most of the patients that, for which conventional ventilation works, those babies essentially don't need ECMO. If we need to escalate, we actually use high frequency on a conventional ventilator. I'd be curious to know if there are any other centers using it, because having been at other centers, Columbia was the first place where I became familiar with it. So on a conventional ventilator, we would decrease the I time to 0.3, increase the rate to 100, and the peak pressure would be around the same. But we are able to rescue most of our babies and prevent ECMO with high-frequency ventilator. We may transition to the oscillator, but it's not necessarily what we use most frequently. We definitely have seen very, very significant kind of utility of high-frequency conventional ventilation for rescues and transport, ability to do bedside procedures, or even we bring our neonatal ventilator to the OR and sometimes do the repairs on high-frequency conventional in the operating room. And lastly, if there is no response, we would go on ECMO. We definitely try to go not delay, as Nissen was mentioning. And if definitely there is persistent acidosis or elevated lactate, we would go on ECMO. Very important for us in the last couple years, we're definitely withholding trying not to use nitric if we do have evidence of LV dysfunction. Because we definitely see that there's more LA hypertension and LV dysfunction when we use ECMO in this kind of population.
Hey, can we just pause to get comments about you guys' starting resuscitative vent settings, ventilator choices? Does anybody want to make comments? I know Katie was whispering in my ear, so.
I think we're currently looking at oscillator versus jet, and one of our neonatologists is doing kind of a study to try to figure that out.
Katie, it's Nick. So
Yeah.
Nick Carr.
Oh, perfect.
Currently at the University of Utah, not quite disgruntled yet, but we'll get there. So I agree. I think, kind of going back to the slides Katie talked about before, with our no ECMO is better for our diaphragm approach. Brad and Michelle Yang, who are leading the study, are looking at high-frequency jet versus oscillator as primary intention. And so in the setting of less is more, we start and we do real gentle, we follow that preductal, and so we try to avoid conventional in most cases from that standpoint. And it's been working well for us, but again, that's again a single center site, and they're working on that study, so hopefully we'll publish it in the future. So.
I did, on that note, I've been told, and maybe I'm just incorrect, but that you can't transport to the operating room on the oscillator.
It's incredibly difficult, right? You've got a fixed circuit from that standpoint, so most of the time that's not the case that we have.
So we repair at the bedside,
Correct.
but you guys go to the OR?
When we mostly go to the OR, but we usually use high-frequency conventional to go to the OR, yeah. And that allows us to both transport and do the procedure in the operating room on that. If there are scenarios where we would transport the patient on the conventional and potentially would go on the oscillator, but as a surgeon, I do think we get the feedback that it's a little bit better to not be on the oscillator to
we
repair,
don't care.
but I
We're
don't
happy
think
to.
you don't care.
We'll
Okay.
fix on anything,
Yeah.
but just how do you get to the operating room?
When we're on the oscillator, for the most part, it would be either manual ventilation, or we usually, if we are on a high frequency conventional, we will transport on the ventilator. Do you have a question?
Yeah. This is Abhi Makar from Oklahoma Children's. I have a question regarding the mode of ventilation. Right now, the evidence is so poor in this, like, we are very much based on that Vicky trial. We are still going for conventional as the initial mode. So I compliment Utah that they are trying, looking for high frequency as, one of the initial modes and what. So if you have very good success rate with this high frequency positive pressure ventilation, and we have talked about or heard recently that there is evidence for trying higher rate, lower I time in this patient population, Have your group thought about, considering using this as an initial mode to see if the outcomes are any better?
Yes, it's actually one of the conclusions at the end of this paper. Thank you for the segue. One of the main trouble that we had is being able to look back in a retrospective way. But our group, the collaboration with our ECMO team, our pediatric surgery team, and our neonatology team, with obviously the blessing of Dr. Wong, looked into these. And they actually were able to go about 15, 20 years to look into the use of high-frequency ventilator. Most of what they look at is if switching from this mode of ventilation to the oscillator is safe. And what they found is that it prevents, actually, you can repair on ECMO earlier, and it's definitely safe. It could be done in transport, to different regions where oscillator is not available. And for the most part, they actually had a better survival rate than patients that were on the oscillator first. Again, this is looking several years back, so what we're looking into now is sort of starting a new kind of arm in which we would do these from the beginning and look into what the outcomes are. Thank you.
Can I ask one question? Steve Peter from Yale. We've adopted your strategy, your ventilator strategy, but then we moved to volume-targeted ventilation. And on volume-targeted ventilation, with the appropriate volume, and worrying more about volutrauma than barotrauma, we're not sure what to do with avoidance of certain high peak pressures. So I was curious whether you use volume-targeted ventilation, and if so, how it fits into your CDH management.
That's a little personal to me because I train at Brown, which is for NICU, which is very, very much volume believer. But then Columbia is a little bit of a different school. So we're actually trying to look into different perspectives. I think the volume part for us at the moment at Columbia is very important while you're on ECMO to try to maintain a minimum of 4 to 5 cc's per kilo to try to maintain that without necessarily having to do high rate or high PEEP. That's definitely when we use a volume strategy at the moment. So in terms of the cannulation, of course, we're looking for having overall more stability, stable saturations, FiO2 that is not more than 40, 50%. We'll have an assessment with echocardiogram and hemodynamics in terms of what we need for pressors, milrinone, nitric. We may use other pulmonary vasodilators, but usually if during the breach we need any inhale iloprost or treprostinil, we would, for the most part, not decannulate. In terms of the bridge itself, we would decrease the flows, and we will have a period that is variable. A lot of the times it really depends on the health of the circuit and how the patient is doing. While we adjust, most of the times we will start on high-rate conventional ventilator, and sometimes we do switch to the oscillator. But if we are on very high settings, obviously we're not going to decannulate. I'm curious, I think there's a little bit of also differences in terms of what we do as a bridge or as a wing, but I think the other speakers are gonna touch base on that. Any questions about that? Okay.
All right. Natalie told me I can have only one slide, so I just put up one slide. But I'm just going to talk about my experience as a pediatric intensivist, and just for the full disclosure, I do not get to take care of all the CDH. So they come to us only if there is a need for ECMO. And we have a unique model where the babies are born in Parkland, and then they have to cross the bridge and come over to Children's Hospital. And within the Children's Hospital, we have the NICU and the Pediatric Intensive Care Unit, and all the ECMOs are done in the Pediatric Intensive Care Unit. So there's a lot of movement, and all of us know all these kids, all they need is just you stare at them a little longer, they're going to fall apart. So I think some of the things that we have done is to just minimize this. So a few years ago, when we found that our outcomes on ECMO were pretty not great, we got together a group of us, a dedicated group of ECMO physicians, neonatologists, surgeons, and we came up with some criteria as to how we would do. We actually have prenatal consults, and so we sit on all the prenatal consults as ECMO physicians. So we kind of know what is coming for us. We have some prenatal markers that we look at. And once we know, there's actually a group text that goes when the the mother is in labor and the baby is going to be born. And then typically within the first 24 hours, whether they need ECMO or not, we try to transfer them from Parkland to Children's. And then depending upon how sick they are, they either go to the Children's NICU or they come to us in the pediatric intensive care unit. And then they typically started on conventional ventilation, but then if they do deteriorate, we have said that everybody goes on the jet. Some of the reasons to do this is, one, we have a good group of respiratory therapists who are very comfortable taking care of the patients on the jet. And the advantage of the jet for us is it's a transport ventilator as well. So we don't have to switch them from one mode to another mode if they have to be transported, to minimize the number of changes that are done to these babies. So that has been a big driver for us to use the jet, and now we have used it so much that we are all comfortable using the jet. So, I mean, I think the message here is that I don't think there is any one magic ventilator, and I think you have to do what is best for your institution and the team integration, because that's ultimately what is going to be good for the outcome. And then the other thing that we have done is we do early repairs, so that we said we are going to repair them within 48, 72 hours before they get fluid overloaded. And this repair is done actually in the room by the surgeon, so we do not transport them to the OR. And then we have an anticoagulation strategy that we work around for these babies. And then, so even during the repair, we keep them on the jet. And then, of course, once we think they are ready to come off, we titrate our jet settings and then try to come off on the jet. And then once they come off and they are stable, they go back to the NICU on the jet. Because there is, as I said, there is so much movement involved of these patients that we have chosen the jet to be our rescue ventilator if they deteriorate, and then we keep them on the jet, repair them on the jet, and then take them off ECMO on the jet, and then transport them. And I think many of these babies also develop air leak at the time of deterioration, and there is some data, as I said, I put some papers here, I think early studies with both prematurity and pulmonary interstitial emphysema babies, the jet had some advantages, and those were some of the driving factors to use jet as our rescue ventilator. With that, I'm going to pass to the next.
Can we just do a quick show of hands for repairs in the OR versus in the NICU? So OR. For OR, who repairs in the OR no matter what? And then who repairs in the NICU or doesn't move them? So it's pretty even, okay. All right, and then who cannulates? So, and I assume the cannulations occur at bedside. Is that fair?
Yeah.
A lot of nods, okay. Yeah.
Hi, David Rothstein, Seattle Children's. One of the tensions I'm hearing or seeing is this phenotype versus standardized approach. And Dr. Rintoul made a good argument yesterday to look at the baby, evaluate echo particularly, and yet Dr. Russell's answer is leave them alone, which I was kind of trained, like, don't mess with them, stop effing around. That'd be Charlie Stoller's answer. So how do we resolve that tension? Do we care what the baby is like? In our group, I'm not part of the CDH team, but they really rely on the prenatal findings, LHR. You know, there's people who are pro-LHR or not so pro-LHR, but that really determines, are they going to be immediate transport ECMO on standby versus like let them chill at the delivery hospital? Thanks.
Yeah, that is the $64 million question. I mean, I think what we have settled on, we know they can get overpoked for sure, but so there's a balance of putting them in the corner, but somebody watching them in the corner.
Yeah, it's just like the, individualizing. individualizing that treatment, right? So it's not always that you can, you need to do the echo right away, because most of them have a fetal echo. So we know that they don't have congenital heart disease. It's more in a baby, if they're okay and you're watching them, you don't need an echo in the first 24 hours. But if they start to desaturate and you're thinking, do they need nitric, then you have to check the left ventricle. You do, because you can make them sicker, right? Or if they're starting to have a worsening base deficit, what is that about, right? Is it just a little hypercarbia that you can fix, or is it the left ventricle? So I think, again, the individualizing the treatment. So there's no rule on when that first echo should be. It's not for heart disease. It's more the whole package and when you need it. So if you can wait, good, but if there's other sneaky signs, then you need to do it. Does that make sense, everybody?
Do you care about LHR or any other prenatal findings?
Well, absolutely. Those are how we stratify and how much we worry. But again, that's just a picture prenatally, right? And so you don't know how that equates to function and the whole pulmonary vascular tree. That's just like size of a lung. So it helps you to worry, but it's not the whole package, right?
Just one comment about the echo part, because definitely if the baby is not doing well, we're going to be like, please do not touch the baby. But there's definitely also a lot of growing work within neonatal hemodynamics and doing a targeted neonatal echo, which you know what you're looking for. It could be done in 3 to 5 minutes. And I think that's really where it's at, not to have an echo tech that perhaps they want to do a comprehensive looking for congenital heart disease study. This should be a very targeted echo, and most of that is really the work, by Patrick McNamara, and we're definitely sort of trying to grow in that regards as well.
Yes, sir.
Hey, Lakshmi. Samir from the Barnard Children's Hospital. We're in a similar kind of situation where most of our babies are born at Regional 1, which is our NICU, and then transferred over. Unfortunately, we don't have a bridge, but they do get transferred over. And that transfer obviously can be a little bit messy, and it creates difficulties. I have several questions, but maybe I'll just restrict myself to one or two. The first question, which kind of really baffles me, is where we say that, you shouldn't stare at the kid, not do an echo, but at the same time, we are talking about doing surgery and cutting this kid open and doing all these procedures. And I'm curious to hear the panel's view, and especially the view from Germany as well, as to why it is that we don't wait for a little while longer for the pulmonary hypertension to settle down before we actually operate on these kids.
I mean, at least I'll tell you from our experience in terms of when they are placed on ECMO, we actually did not do early surgical repair. And we found that always, one, we struggle to get them off ECMO, and after they get off ECMO, then in the peri-surgical period, if they fall apart, then the whole question of recannulation becomes a big challenge. So that is one of the reasons. And then just around the time when we were debating, there was the single center data from TCH that showed that they had good outcomes. And so we had to convince our surgical group, and we had so much good outcome with early surgical repair on ECMO that they have now started doing that even for the non-ECMO patients, that they do early surgical repair. And the other challenge for us is we have about 40 neonatologists, 20 intensivists, 10 surgeons, and 3 different units. So unless I think we have to personalize care, but at the same time, I think it is helpful for us to have some protocolized way we can assess and do things. Do all of them need early repair? Maybe not. Would some of them do just fine? Probably. But I think, one, your numbers, it's not like you're doing 30 CDHs a year that you can rapidly build your experience. It takes time. And when you have a large group, 3 different units, and the patient numbers are sparse, I think the best way would be, in my mind, to have something protocolized, and then to kind of tweak your this one. One of the things we had to tweak was the anticoagulation, because around surgical repair, we would always stop the heparin, give Amicar, do all this, and then I always felt like the night of the surgical repair, I would always hear this from the specialist, oh, the 8 French arterial cannula clotted off, we had to pull out clots. So then we said after 3-4 years, let's revisit the anticoagulation. So we had to tweak that. So that's why I'm saying it is, and we always, I don't know if Dr. Case is in the crowd, his outcomes are so good. But again, I think it's just one person essentially running this one. So I think we have to take all of that into consideration. Is this one, but I'll also leave it to, as I said, my experience with CDH is only when they come to the PICU.
Can I just ask a follow-up to what you said before you respond? And that is about, you mentioned about the number of intensivists and the neonatologists and the surgeons. So do you have a CDH committee or a team that rounds and follows each and every patient every day?
Yep, okay. We have a CDH work group that involves the surgeons, the neonatologists, and from the ECMO team. So we get a text, all of us are involved in the group text. We all sit in the prenatal consults, and once the mother goes into labor, we all get a group text saying that, hey, this mom is in labor, these were just to enlighten us, these were the prenatal factors, this is what we said in the consults, and yes, we have that kind of discussion.
So it's fascinating. So we have to get on to Matteo because he's full of charm and...
Yes.
So thank you very much for the question. First of all, I have to admit we do an echo on the kids in the first hour of birth with every CDH patient. And we even follow up on that echo if there's deterioration. And this is important for us because all the findings are important to initiate ECMO or not. We look at the aortic arch, we look at the TI, we look at the bidirectional flow in the patent ductus. So this is all important for us to initiate it ECMO or not. Why is that? When a kid on inhaled NO then fails to respond to it, we think that ECMO, and we do low flow ECMO on a roller pump, is the biggest treatment for pulmonary hypertension because you reduce the pulmonary flow and you allow the vascular bed to relax and remodulate. So that's why we initiate echoes very early, look at the hemodynamic situation, and then decide whether we take them on ECMO as a treatment of the pulmonary hypertension or not.
So Sarah, you...
Oh yeah, sorry. Sarah Kane from Atlanta. This was kind of on the comments Katie had from Utah, but I'm just interested in the what people are doing about IV access if you're trying to leave the kids alone, because I feel like we often send the echo people away or wait for somebody who's going to be quick, but the C's and D's, the UVs never go, right? So then we have a 2-hour ordeal placing a PIC, and then that's the kid that ends up going on ECMO. So I just wonder how people are handling that if you're trying to leave them alone.
IV access is the question.
No comments.
IV access? I mean, we place the central line right in the delivery room and the arterial line right in the delivery room within the first 15 minutes of the child's birth.
We also, 15 minutes, I'm impressed. But yeah, we also in the transitional nursery, that's how we call the delivery area, we place a pre-ductal arterial line and UVC or a PIC line, depending.
Matteo, we've been waiting so long. Some things are worth waiting for.
No problem at all. Now we skip in Rome, what we do there. A couple of comments to start. We didn't speak so much about sedation. I think it's important when we speak about CDH, especially when we think about central lines, arterials. These are things that are important to monitor our patients, but can trigger and increase pulmonary hypertension. So remember that there is the sedation. The other things, you ask me why we immediately made surgery during ECMO. Mainly for one reason. We do not have such a number of ECMO cases for CDH every year. So we presume, and I say we presume, that the ones that goes on ECMO are the most complex one for our neonatologist. So the reason why we cannulate and we operate after a couple of hours when we move the patient from the neonatal ICU to the pediatric critical care where I work is just because we would like to use the effect of the coating of the ECMO pump and the circuit to reduce as much as we can the use of heparin. This is the main reason that why we operate immediately after, because we don't like to stop heparin after 48 hours and things like this, or to reduce the level of heparin. By the way, I'm not using any more heparin, I'm using bilivarudin, just for transparency, but the same concept. Anyway, briefly, the reason why we have some problem with CDH, according to my experience, are generally an inability from us to maintain adequate gas exchange. And this is obvious because, as we can see in the slides, we have a reduced functional residual capacity in a CDH patient. The pulmonary vascular resistance quite often are very high, and we often forgot that in some cases when there is left ventricle hypoplasia, this left ventricle is untrained to receive a huge amount of blood after birth. So I don't have a special recipe in Rome to set the mechanical ventilator during ECMO, but it seems to me obvious that we all want to reduce the ventilator or ventilation-induced lung injury. So we reduce the ventilator settings, but when we do this, we monitor what we do, and we will discuss a little bit. What is important to me to highlight here, and this probably because basically I am an anesthesiologic background, is that when in the operating theater we manage the thoracic surgery, we manage an asymmetric lung injury. And an asymmetric lung injury is almost what we have in a CDH patient. And as you can see there, one of the two lungs is collapsed. This is a gross way of thinking things, but ventilation and perfusion, in general, especially the perfusion, goes very well with the gravity. So in practical, the lung that is not injured, that goes in lateral decubitus, receive much more perfusion and oxygenate well. And this graph here shows you how the PaO2 changes with the decubitus during thoracic surgery. But coming back to CDH, the most important things to realize before ECMO and during ECMO when we ventilate this patient is that the tidal volumes goes where there is space and goes accordingly to the compliance of the respiratory system. Now, the respiratory system compliance here should be partitioned into hemithorax, one where there is the non-injured lung and the other one when there is the collapsed lung. And this, according to me, is important, especially if we do not measure it. Because when we look at the total respiratory system compliance, we have only just one number. But as you can see here, there are three curves. The top one is the compliance of the respiratory system, but each lung has its own compliance, and each lung receives a percentage of the total volume that we set on the ventilator. It's difficult to manipulate and to monitor this, but nowadays there are devices that allow at least to have an idea of what is happening. These devices are much more known in the adult critical care, have moved also to the pediatric critical care, but can be used, thanks God, also in neonates. And if we use electrical impedance tomography, at least we can have an idea of the ventilation distribution between the two lungs. It is not so easy in CDH because a great part of the lung sometimes is collapsed by the bowel, but if we put the belt a little bit up, we can often get some part of the lung that is collapsed, and we can understand how much of the tidal volume goes there, and also calculate the compliance of each hemithorax. This has been applied during ECMO for children. This is an experience that we had. And what I would like to say is that when we set our mechanical ventilation setting, particularly PEEP, before ECMO or during ECMO, what I usually do, and this has been suggested by the adult, is trying to find a compromise between the over-distension that we can induce, especially in the non-injured lung, and the collapse. So here, there are some curves that we can do with this device when we do a decremental PEEP trial, trying to find the PEEP that we would like to apply to our patient. And we find, and we try to apply the one where we have a good balance between collapse and over-distension. And this is the approach that I try to use, and also my neonatologists are trying to use. Going to finish what we do in Rome for weaning and decannulation. When we think that our patient is ready to be weaned, the day before the weaning trial, we just prepare the mechanical ventilation in the way that we would like to use after the ECMO has been weaned. So we reduce the FiO2, trying to stay no more than 50%, because if we stay more than 50%, after the cannulation, if we have problem, we cannot manage, and we have a less rescue approach. We reduce the tidal volume to 4-6 ml per kilo, trying not to over-distend the lungs, and we control with TIT. We use the PEEP accordingly, and generally we start in almost all of our patients the nitric oxide the days before the weaning. The night before, we also reduce the 10% every 6 hours the pump flow, trying to go to the following day to a certain amount of blood flow in the ECMO pump that allows us to understand if things are going well or not. If things are supposed to go well, we do not stomp with a centrifugal pump the ECMO when the pump flow is at the limit for the oxygenator. We don't use the bridge in Rome, but we apply this technique over here that is called PCRTO, Pump Control Retrograde Flow Trial, where we go down with the pump flow. We inverted the flow, as you can see, from a normal VA ECMO to a PCRTO. And we try to maintain for a couple of hours a pump flow retrograde of more than 100 ml minute. And we stay and we check the blood gas analysis for a couple of hours. If everything goes well, and we didn't have any problem, not only in my group, of course, the technique has been published by other group, we come out, and if everything goes well with this approach, we have never had the chance to come back on ECMO for some problem that we have immediately. Last two things.
So just on Matteo,
yeah.
Is it going through the membrane? So it's almost like a reverse?
Exactly.
So it's going through the oxygenator?
It's going to the oxygenator, yeah.
All right, so it's almost like pumpless.
It's pumpless. It's your heart that is pumping.
Right, so you're testing the heart, but you're still using the membrane.
But the membrane is not oxygenating.
Oh, okay.
It's not
Oh,
we do this to keep the ECMO going on.
Okay, got that.
Last two slides. As you know, there is a group of guys around here that works with a CDH interest. It's called the CDH interest group. This group has provided some literature in the past year. One of the recent papers has been this. Gunnar Jeet from Orange County in California is our mentor. And last year we published this experience regarding the standardized mortality ratio among the elsewhere registry. As we know, the mortality CDH is fixed, but there are centers where the mortality is high, centers where mortality is low. To understand if this was due to practice, because now we have guidelines for the management of pre-ECMO, management of ECMO published 2 years ago or last year, we try to do this analysis to standardize, according to the patient characteristic, the mortality, and we evaluate, and we found that there are some centers, the one in green, that really perform quite well, and the other one in red instead had a higher standardized mortality ratio. We were not happy about this because we realized that some factor that happened during ECMO cannot be controlled by this analysis. And we wanted to check the impact of centers volume on outcomes, because we know that the more we practice, the better we are. And we did another analysis, this is not published yet, it's going to be submitted, where we tried to check if we can classify the previous centers according to the volume of activity in low volume, medium volume, and high volume. And what we found, using this classification, considering low volume below 2 cases every year, is that the odds ratio for mortality is 54 higher in low volume center than in high volume centers. So this confirms that the practice that we have can improve outcomes. And this is only to justify why center with low volume performance should transfer this kind of patient in center where the experience is much more wider. I'm going to finish with the same sentence that you saw before. These are important publications that have been discussed, but what is important is to meet the baby, to look at the baby, to monitor the baby, to understand the baby. And thus, the chances of doing a good job are very high because we have all the instruments to do it. A team working, according to me, is fundamental between neonatologists, intensivists, surgeon. And knowing the rationale makes the difference. Let me conclude with the slides, because my hospital is in the Vatican City. And of course, it's mandatory to me to say hello in this way. Thank you.
Thanks, everybody, for an engaging hour. Thank you for your participation. It was fun.